have the honor to present two really well-known experts in the field. The first one is Professor Bautmans from Brussels. He's teaching at the Vrije Universiteit in Brussels. He's internationally well-known because of his work in physical training, in sarcopenia and inflammation, and he has been recently honored by receiving 6 scientific awards on his work on muscle fatigue and frailty. And he's also board member of the Belgian Society for Gerontology and Geriatrics and a founding member of the Belgian Aging Muscle Society. It's great to have him on board. He will talk about how hard and how often we have to exercise. This is truly about dosing exercise in our target population.
Thank you, Dr. Bauer, for the introduction. So in the coming 50 minutes, I will talk about the intensity and efficiency of resistance training in older persons with sarcopenia and frailty. So these are my conflicts of interest. Aging is accompanied by important changes in body composition. In fact, between the age of 30 and 70 years, we lose on average 4 to 6 kilograms of skeletal muscle. This phenomenon is defined as sarcopenia. Intriguingly, also the proportion of skeletal muscle relative to body mass reduces by 4 to 6%, which means that the loss of muscle is compensated by an increase of other tissues, which is mainly adipose tissue and fat. Sarcopenia and physical inactivity are accompanied by important metabolic alterations. In fact, increased adiposity contributes to chronic low-grade inflammation, which on the one hand accelerates the development and progression of several chronic diseases, and on the other hand, it enforces the age-related changes in the immune function, characterized by an inflammaging profile. Inflammaging is typically an imbalance between circulating pro- and anti-inflammatory biomarkers. All the subjects showing this inflammaging phenotype are more prone to develop frailty and show reduced life expectancy. Recently, we developed within the Belgian Society for Gerontology and Geriatrics a clinical practice guideline for the evaluation, prevention, and treatment of sarcopenia. We found strong evidence for resistance training as a key element in the prevention and treatment of sarcopenia. Additional effects can be obtained by combining resistance training with nutritional supplementation, a topic that will be discussed by Dr. Phillips in the next lecture of this symposium. So let's talk about resistance training. It's not surprising that this type of exercise has a major place in the recent World Health Organization guidelines for physical activity in older persons. In fact, the WHO published in 2020 an updated guideline on physical activity and sedentary behavior. These guidelines include specific recommendations for older adults with chronic conditions, such as cancer survivors, arterial hypertension patients, type 2 diabetes patients, and HIV patients, as well as for adults living with disability, including older adults with multiple sclerosis, spinal cord injury, cognitive disorders, etc. Besides the recommendation for a sufficient weekly volume of aerobic physical activity, WHO advocates at least 2 days per week resistance exercise, and this for all categories of older adults. Typically, resistance training consists of performing muscle work against an external resistance. This external resistance can be produced by one's own body weight, using free weights, or specific exercise machines. Moreover, resistance training can be performed at various modalities depending on the level of external load, the number of repetitions, the speed of movement, the number of series, and the duration of rest in between the series. The external load is defined by the 1 repetition maximum, which is the maximal weight that can be moved or lifted only once. This maximal strength needs to be assessed for each person individually in order to be able to design a good exercise program. Key for a proper resistance training workout is to induce muscle fatigue at the end of each series of movements. Resistance training using maximal external load, which is 70 to 80% of the 1 repetition maximum, has been shown to be the best method to increase muscle strength in older adults. At this external load, one is able to perform about 8 to 12 repetitions before the exercising muscle is tired. 3 series with at least 1 minute rest in between provides the ideal workout. Although it is very a very safe type of exercise, it's recommended to start the first exercise sessions at a lower external load, such as 50% of the 1 repetition maximum, for example, and to increase progressively the external load by about 10% every 2 to 3 sessions, until the submaximal level of 70 to 80% of the 1 repetition maximum is reached. At least 1 day of rest between the exercise sessions is recommended. This progressive increase of external resistance will allow the older person to get acquainted with the exercises and will avoid excessive muscle soreness to the days after the first exercise sessions. So this will increase the adherence to the exercise regime. This type of exercise training has been extensively studied in older adults. In this figure, the effects of resistance training on the knee extensor muscles is shown for 51 cohorts of older adults. Each horizontal line represents the effects of 1 cohort. On the x-axis, the strength gains after 6 to 12 weeks are shown as measured with the leg press device. This is an exercise machine during which the subject has to push a weight with both feet together and corresponds to the movement performed when raising from a chair. And as you can see, strength gains between 15 to 60 kilograms can be expected, which corresponds to a spectacular effect and which translates in important functional gains at higher age. In this study, we show the critical importance of proper exercise prescription. Here, we compared the effects of resistance training in older adults using 3 different exercise regimens. The high group performed traditional resistance training and performed 2 series of 10 to 15 repetitions at 80% of the maximal resistance. The low group performed 80 to 100 repetitions at a low external resistance of 20% of the 1 repetition maximum. The low plus group performed first a series of 60 repetitions at 20% of the maximum resistance, immediately followed by 10 to 20 repetitions at 40% of the maximum. The 3 groups performed a comparable exercise volume, however, using different external resistances and numbers of repetitions. All participants trained 3 times per week during 12 weeks. And as you can see, the most rapid and highest strength gains were obtained at a high external resistance. The low plus group reached a comparable but somewhat lower strength gain, and in contrast, the low group showed a significantly lower strength gain. In fact, the low group muscle strength improved by only 20% compared to 45% in the high group. These rapid strength gains can partly be explained by an improved voluntary activation of the muscle. In fact, all the individuals show a significant deficit to fully activate their muscles. Although the muscle fibers are present, all the persons are unable to contract all fibers together, thus leading to this activation deficit. In 2014, we performed a systematic review on the effects of resistance training on voluntary muscle activation. This review was recently updated by James et al. Literature data show that resistance training significantly improves the voluntary activation of the muscle in older persons. This means that older persons show a hidden potential of muscle strength that can be reactivated by means of prescribing the proper exercise intervention. Also, gains in muscle mass can be obtained by resistance training at higher age. In fact, an increase of 7 to 10% muscle hypertrophy can be obtained after 10 to 16 weeks of resistance training, even in very old persons. Besides the effects on muscle strength and muscle mass, exercising the skeletal muscle induces several metabolic and systemic effects. One of these effects is the anti-inflammatory response following exercise. In fact, during exercise, as shown here, where an older volunteer is exercising her thigh muscles on the leg press device, the exercising muscle produces several proteins that have autocrine, paracrine, and endocrine effects. These proteins are called myokines and are released by the muscle fibers into the circulation. One of the best characterized myokines is interleukin 6. And during exercise, interleukin 6 is being released by the muscle in a dose-response relation. In fact, IL-6 acts as an energy sensor. When the glycogen stores of the muscle are being depleted, IL-6 is massively released in the muscle or by the muscle. And this IL-6 is not reflecting a muscle inflammation, but will stimulate release of glycogen from the liver and lipolysis in adipose tissue in order to provide the necessary energy for the muscle to continue the effort. That's what you see here. However, since interleukin-6 is also an inflammatory-related cytokine, interleukin-6 will stimulate and trigger circulating immune cells to an anti-inflammatory response, which is characterized by the secretion of anti-inflammatory cytokines such as IL-10, IL-1 receptor antagonist, and soluble TNF receptors. After 24 hours, this acute exercise-induced immune response is washed out, and it's time for a new exercise workout. On the longer term, these repetitive myokine releases and subsequent anti-inflammatory responses will create a shift from an inflammaging profile towards an anti-inflammaging one. In 2005, we were among the first to demonstrate that a single regular resistance training session is sufficient to obtain an average increase of about 20% in circulating IL-6 in older adults, aged 60 to 80 years. In untrained condition, training induced an increase of IL-6 and the tendency of IL-10 to decrease. In trained condition, the decrease of IL-10 disappeared, which shows an adaptation over time. In the same study, we have shown that already after 6 weeks resistance exercise, which is very short, basal levels of IL-6 tended to decrease and IL-10 to increase, thus reflecting lower inflammation. In another study, we found a significant decrease in basal levels of IL-6 after 12 weeks resistance exercise in elderly persons. This suggests that a sufficient amount and duration of resistance training is needed to allow a net decrease in inflammation in older adults. Since then, numerous inflammatory biomarkers have been studied in the context of resistance training. Importantly, a distinction must be made between the acute exercise-induced response and the effects of several weeks of training on the basal levels. As can be seen from this overview, there are some inconsistencies between different studies. And most often, this is related to differences in the type of training and the external resistance used. As an example for the importance of the exercise intensity on the effects on inflammation, I come back to the study that I discussed earlier, where we compared 3 types of resistance exercise. As you remember, the high group performed traditional resistance training and performed 2 series of 10 to 15 repetitions at 80% of the maximal resistance. The low group performed 80 to 100 repetitions at a low external resistance of 20% of the maximum, and the low plus group performed first a series of 60 repetitions at 20% of the maximal resistance, immediately followed by 10 to 20 repetitions at 40% of the maximum. Our results show that 12 weeks of supervised resistance training induced an overall significant increase in circulating IL-8 and soluble TNF receptor 1, independently from the external load applied. We suggest that exercising until volitional fatigue is the main trigger for exercise-induced responses. However, training at high external load also increased anti-inflammatory IL-1 receptor antagonist in the male participants, which might be beneficial in combating low-grade inflammation and again documenting the importance of proper dosing of the exercises. I herewith will finish my lecture by some take-home messages. Firstly, sarcopenia can be countered by physical exercise with important gains of muscle strength and muscle mass, which can be explained by both neuromuscular adaptations and muscle hypertrophy. Physical exercise leads also to a systemic response, which is a myokine-mediated phenomenon with anti-inflammatory effects. These systemic and immunological responses provide additional therapeutic targets for exercise prescription. One must be aware of strong dose-response relationships. And therefore, my recommendations for clinical practice are to propose sufficient exercise volume and intensity. And given the overwhelming scientific evidence for the beneficial effects of resistance training, implementation should be a priority. Lastly, I herewith provide you information on a new research master program in gerontological sciences that has been initiated at our university. This research master is aimed at excellent bachelor or master students who are interested in research in healthy aging and it is an excellent preparation for a PhD in the domain of healthy aging. If you have any questions regarding this research master program, please don't hesitate to contact me. I hope you enjoyed this lecture, and I'm ready to do my best to answer all your questions.